Please start, sir. We are live.
Good evening, everyone. I would like to welcome you all for today's webinar on Oncology Treatment Update 2024. With immense pleasure, I would like to welcome Dr. Anupam Mehta, sir. Sir is Senior Consultant Medical Oncologist, Health City Hospital, Guwahati. For the welcome and introductory note, the stage is all yours, sir. Over to you, Anupam, sir.
Yes. First of all, I offer my sincere thanks to the Cancer Research and Static Foundation in collaboration with AstraZeneca for a CME on updates on lung cancer. And it is we all know that lung cancer is the leading cause of cancer-related death worldwide, and much progress has been made recently, such as screening, minimally invasive techniques such as advances in radiation therapy, including SBRT, new development of new targeted and immunotherapeutic agents, and these new treatment strategies are reflected in the improved overall survival rates. But patients with lung cancer who are eligible for targeted therapies or immunotherapies are now surviving longer. 5-year overall survival ranges from 15 to 50% depending on the biomarker. Although death rate is declining, but lung cancer is still, there is more death from lung cancer than breast, prostate, colorectal cancer, or brain cancer. And today we'll have 3 speakers and one panel discussion. And first, I would like to invite Dr. Duncan Khoniker. He is a senior consultant medical oncologist, Assam Cancer Care Foundation, Dibrugarh, Assam. And Duncan will speak about the molecular biomarker testing in lung cancer. Welcome, Dr. Duncan.
Thank you, sir. Thank you, Anupam, sir, for the kind introduction. Am I audible?
Yes, you are audible.
Okay. So thank you, sir. And I thank Cancer Research and Statistic Foundation as well as AstraZeneca for the opportunity provided to me to be a speaker in this webinar. So can anybody share the slides for me?
Slides are visible, sir?
Yes, visible.
Yeah. Yes. So the topic of today's discussion is molecular biomarker testing in lung cancer. We all know lung cancer, apart from breast cancer, these are the 2 cancers which have paved our way of understanding cancer. So the new age of individualized medicine in cancer patients has come from understanding of the molecular biology of lung cancer as well as breast cancer in a big way. So we will try to understand the new molecular biomarker testing that are implemented nowadays in day-to-day practice in lung cancer. So can we have the next slide? Yeah. So the today's content will be divided among some epidemiological information as well as important concepts about biomarker testing in NSCLC, non-small cell lung cancer, where we will concentrate more today, and how it has evolved in the current years. Yeah. Next. So the burden of lung cancer in India, this is important because we must first try to understand the problem statement. We already know lung cancer is one of the most common or among the top rankers among all the cancers prevalent in India as well as worldwide. Can we have the graphs? Yeah. So with respect to the new cases in 2020, in India, lung cancer ranks almost 3rd or 4th among all the cancers. And can we have the next slide? Yeah, next. So the important thing that we must understand is the previous slide. So the important thing we must understand is lung cancer is one of the most common cancers in India as well as worldwide. But the most problematic thing is, as Anupam sir has already stated, it is also one of the most deadliest cancers. Probably in the table provided, it is ranked among the fourth most common fatal cancers. But I believe it ranks among the second or third, or even in the first position among the number of mortality with lung cancer. So lung cancer incidence is also high, and the mortality rate is also high. So this is the major problem we are now facing still with lung cancer. Yeah, next. But I probably feel this is the most important slide, and this is what uh, forms our idea of individualized medicine. We find that 50% of patients with advanced non-squamous non-small cell lung cancer have a particular driver mutation, and which we can target till date. So as you can see, we have a number of common familiar names like EGFR, ALK, ROS, some terms like MET exon 14, even HER2 mutation as well as amplification, then BRAF. So there are a number of even KRAS. So these are the driver mutations that have been identified in almost 50% of patients with non-squamous non-small cell lung cancer, and these have targeted therapies. So this is what defines our new age therapy in lung cancer. Next. So here lies the importance of biomarker testing in non-small cell lung cancer, because as we can see from this graph as well as from our day-to-day clinical practice, that those who have a driver mutation, they survive or they fare much better with a targeted therapy than those compared to those who don't have a driver mutation. Next. So there are a number of guidelines, NCCN primarily, as well as ESCO, ESMO, and they have provided us guidelines to define our treatment decisions and which biomarker or molecular testing to be done. So as you can see, there are a number of molecular mutations stated, and as per NCCN and ESCO, we must go for the full panel of molecular testing, because most of them at present have a targetable therapy, and if even if we don't have a targetable therapy, they provide a prognostic information. So our biomarker testing is important both for treatment as well as prognosis. Next. So how do we go about testing for these molecular mutations, or detecting these mutations in non-small cell lung CA? So that there are a variety of methods. DNA sequencing or NGS is one of them. RNA sequencing panel. This is a much better method of detecting mutations or molecular analysis. IHC and FISH are probably the fastest way to detect. However, they lack a particular degree of sensitivity. However, in certain cases like fish is important in elk or ross detection for the rearrangements. Probably, if you consider the which will be the best one, probably RNA sequencing will be the best one. Faster, if you need a more thorough analysis, then probably NGS or DNA sequencing would fare much better. But whatever it is, we have different methods which we need to modulate based on our patient's needs, financial constraints, as well as the rapidity or how quickly we need the information. Next. Next. So, how has all the biomarker tests evolved throughout the years? This is an algorithm on how a diagnosis or a new case of lung cancer goes through the steps of diagnosis with biopsy, a histopathological evaluation, and then how to plan for molecular testing. So, this is what we routinely do. Okay, so in the past, we were far more confined, and probably even we were content with an FNSC. But nowadays, we need more tissue. So a biopsy is always preferred, and FFPE block is always needed, so that we can extract as much tissue as possible, so that we can uh, put the biopsy block for further molecular testing. And as I've already stated, we can go for DNA sequencing or RNA sequencing or even the protein evaluation. So we have a multitude of methods of detecting the mutations or rearrangements that we require to detect particular molecular defects in lung cancer. Yeah, next. So our approach should be holistic in a way, and it should include oncologists as well as radiologists as well as pathologists. So first of all, we must determine in a new case of lung suspected lung malignancy whether it is squamous or non-squamous. So if it is non-squamous, we are probably more attuned to molecular analysis, and the lesion which is more preferred is probably a metastatic lesion, because that will also define that the stage of the disease. However, there is hardly any discrepancy in molecular analysis between the primary tumor and the metastatic lesions. So any lesion can be preferred, whichever is the most accessible or feasible. Bone biopsy probably provides us with suboptimal tissue, because we need to decalcify, and that might degrade the DNA. Now we have a new tool at hand, liquid biopsies, which have provided us with a new paradigm to analyze these molecular mutations. So, whatever it is, suppose the patient is a non squamous lung malignancy, or even a squamous lung malignancy in a very young non smoker, then we can go for the routine testing of EGFR L cross, and most prefer BRAF, NTRK, RET, and MEX exon 14 as per new recommendations by NCCN as well as ESCO. Then we must also consider for PDL1 testing in all NSCLC, whether it is squamous or non-squamous. The thing is, the output time usually requires almost 2 weeks. So this is the time frame that we must work on to arrive at the full analysis of the molecular panels. So it usually requires 2 weeks roughly. Next. So circulating tumor DNA is probably the new age way of analyzing molecular mutations in our cancer patients, and probably it is important in diagnosis and treatment selections in a few cases where we can't do a biopsy. But the most important patients where circulating tumor DNA is important are during monitoring of the patient's response, and whether the patient has progressed or relapsed or has a relapse of the disease. Probably circulating tumor DNA testing is more important during monitoring of the patient during his or her therapy. Uh, as I've already stated, during diagnosis, probably if we don't have an accessible tumor lesion to biopsy, then probably circulating tumor DNA will come handy. So the endpoint is circulating tumor DNA testing may never replace tissue biopsy entirely because it provides us with the best histopathological tissue for further evaluation, but definitely it aids as a supportive way to guide us during certain critical times. Next, next, next. So the concept of MRD is quite new with non-small cell lung CA, and we are really not sure the whether MRD uh, gives us the same important information as it provides us with many other liquid malignancies. But whatever it is, probably circulating tumor DNA will try to detect the minimum residual disease. And as we have already understood from a few studies, that patients who have an MRD positive, they recur faster. So the impact of MRD in NSCLC with respect to overall survival is still doubtful, but at least we understand that those who have an MRD positive will recur faster. Yeah, next. So how do compare TC or versus liquid biopsy? As you already understand, uh, tissue biopsy requires invasive surgical procedures, where liquid biopsy is a simple blood test. And serial testing or repeated testing for tissue biopsy is quite difficult for a patient and painful as well. Whereas liquid biopsy, the blood test, you can repeat it anytime. And the best thing is the tumor cell content is much better with tissue biopsy, and we gather substantial amount of cells for further molecular testing as well as tissue for molecular testing. However, liquid biopsy is limited by the amount of cells or circulating DNA that have been collected, and we need very sensitive methods to detect circulating tumor DNA. So these are certain challenges that we have till now with liquid biopsy. That is why it is preferable to do a tissue biopsy. Next, next. So this is actually a flow chart which shows that there are two ways to go about analyzing the molecular mutations in non-small cell lung cancer. We can go for single gene testing. We can go for testing of each of the important mutations like EGFR, ALK, ROS, RET, MET exon 14 one by one, and check whether it is mutated or not. If it is mutated or identified, we can go for targeted therapy, or we can go for testing of the whole bunch as a whole with NGS, next generation sequencing, and then we collect all the reports, and then we analyze which to target and which patients don't have a molecular mutation to target. Next, next. So let us now understand what are the advantages of NGS. So NGS has a number of advantages over single gene testing. As you can understand, NGS is costly in a way compared to single gene testing. But as you can see here, the number of biomarkers, with if we go on testing more and more biomarkers, probably lies with NGS rather than single gene testing. Plus, the turnaround time is also minimized with NGS. If you go on doing a bunch of biomarkers one at a time, then single gene testing will take a hell lot of time actually. So, probably in a way, we must be able to stratify the patients whom we want to do the whole set of biomarkers and whom we have to restrict to a minimum number of biomarkers. If you want to restrict to a minimum number, probably single gene testing will be preferred. But if you want to do the whole bunch, then probably NGS is probably the best way. Next. So these are techniques that are used frequently for molecular testing. These are actually single gene assays are there, singular sequencing, pyrosequencing, allele specific, and each of the test carries an important identification point for a particular mutation. For example, allele specific PCR is more preferred for EGFR and to detect T790M mutations. But whatever it is, the process of sequencing our molecular mutations have become more and more complex, and we have to have a far better idea of which test to select. Next. So this is actually the molecular landscape of non-small cell lung cancer. This is quite a busy slide, but what it states is the 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 table of all the molecular mutations that we usually test: EGFR, KRAS, MET, ELK, BRAF, ROS1, RET, NTRK, HER2, and many other emerging biomarkers. So these have a particular targetable mutation. I'll not go about. As you can see, probably EGFR, the incidence of or prevalence of EGFR mutation is far more common in the Asian population. 30 to 40, even may go about to about 50 to 60%. In comparison, KRAS mutation is far more common among smokers, even if they are adenocarcinoma. And rest other mutations are not that prevalent. And that's why their frequency comes with single digit numbers. And each has a particular specific diagnostic approach. For example, we prefer PCR testing for EGFR. For ELK, we already know we can test by IHC with proper platform, as well as ROS with proper platform, and might have to confirm it with FISH. So we have to go through the entire best diagnostic approach for each molecular mutation. Probably this is where NGS uh, reduces the information that we require by covering all the mutations and providing us with a comprehensive list at a single point. Next. So let us talk in short about EGFR mutations in lung adenocarcinoma. So the sample used for EGFR mutation is FFPE, fresh frozen paraffin embedded sections, fresh or alcohol fixed specimens. Even cell blocks are also preferred. And as you can see from this table, actually this table is a bit skewed, but what it states that whether you analyze EGFR mutation from the primary tumor or the metastatic tumor, there is hardly any difference. So the rate of discordance of EGFR mutation between primary and metastatic tumors is very rare. So you can test EGFR from any site. Next. Next. So till now, actually, we were more attuned to testing molecular mutations in advanced stage or metastatic non-small cell lung CA. But this is what is considered a new paradigm, that we should also test for EGFR testing even in early stage NSCLC, and even with 1B, 2, 3A, 3B. Probably it is important that we test for EGFR mutation, because we can consider for adding TKI as an adjuvant therapy in these cases. So this is what has put EGFR testing, and for that matter, any molecular testing in non-small cell lung CA more important right now. That you should test even with early stage cancers. Next. Next. So this is again a reiteration. I will not go in details. No, similarly, what about ELK? So ELK, as I've already said, ELK IHC is again 93 to 100% sensitive and specific compared to FISH with a proper platform. So probably for ELK IHC is okay. Next. What about ROS1? ROS1 probably we go about by testing with IHC, and to confirm we go for fish. Yeah. Next. So KRAS mutation has been popularized by the new TKS that are available to target KRAS, and that is why the importance of KRAS lies not only with prognosis but also we now have a targetable therapy for it. So the testing for a single RAS KRAS G12C testing, that is what we can target right now. Although it is not currently routinely recommended, and whether if you want to test it, we should do it by NGS. Next. Similarly with BRAF, this is also not widely recommended, but IHC and PCR are both generally accepted methods. And generally, this comes as an information out of NGS testing. Next. Similarly, c-MET exon 14 skipping mutations for which we have good drugs right now. This can also be tested. And usually, if we want to test this, we can go for NGS testing. But the increased sensitivity is already stated with RNA NGS actually. Next. Next. So if you want to test MET exon 14, probably we should go with NGS multi-panel, multi-gene panel. Yeah, next. Red fusions also we have targeted therapies for red fusions, and once again these are emerging mutation biomarkers, and probably an NGS will be a much better way of analyzing these mutations. Next. Next. Anti-RK fusion, similar. These emerging biomarkers are well placed with NGS testing rather than single gene testing one by one. Next. Next. HER2 mutations. So HER2, there are two issues with HER2. There is HER2 mutation as well as HER2 amplification in non-small cell lung adenocarcinoma, and mostly HER2 mutations are exon 20 in-frame insertions. They carry very worse prognosis, so they have a prognostic importance. And IHC can be used to assess HER2 overexpression that we usually do with breast cancers as well as nowadays with stomach cancers. But probably the it IHC is probably not yet standardized with respect to non-small cell lung CA. So we actually really don't know what is really HER2 amplified in non-small cell lung CA. We probably extrapolate it from breast as well as stomach CA. But both HER2 mutation amplification can be identified using NGS DNA panel. Next. So this is again a repetition. The entire paradigm of molecular biomarker testing in non-small cell lung CA. So as you can see, there are 1, 2, 3, 4, 5, 6, 7, 8 mutations that we usually need to test. And except for EGFR, ELK, ROS1, others like BRAF, NTRK, RET, Metexon, and KRAS are probably better tested with NGS. NGS RNA is probably preferred, or if not, NGS DNA. Whatever it is, these have targeted therapies. I will not go into details about the target therapies available. We already know the names, but this is how we nowadays plan our management for patients with a targetable mutation in non-small cell lung CA. Next. So what about PDL overexpression? So PDL1 testing has its issue of particular complementary platforms for each immunotherapy. As per blueprint project, probably we can generalize all the platforms for each immunotherapy. But till now, if we want to give a particular immunotherapy, for example, pembrolizumab, we have to check for the PD-1 status by 22C3 antibody clone, and similarly for other immunotherapies. Uh, So the positivity of PDL1, whether it is significant or not, it varies based on the platform. Uh, yeah, next. So these are different antibody clones that are used for testing of PDL1 in non-small cell lung CA. Next. So the issue is different scoring systems are used. The problem with PD1 or PDL1 is that probably as we are slowly understanding the effects of immunotherapy, we have begun to realize that probably PDL1 is not a very good biomarker to tell us whether immunotherapy will work in a particular patient or not. We have seen that there is a synergistic effect of immunotherapy with chemotherapy. So, irrespective of the PDL1 status, if you combine immunotherapy with chemotherapy, it provides a survival benefit. Tumor mutational burden is also a form of biomarker to assess response, but it is not currently routinely used. MSI high or MMR is another way, but it is not usually used in lung CA. LAG3 is another way to assess whether patient will LAG3 will provide us whether patient will respond to immunotherapy or not. But till now, we are in search of a very good biomarker to assess to state whether the patient will respond to immunotherapy or not. Next. So, in conclusion, biomarker testing in non-small cell CA has evolved from single gene testing to probably a more comfortable multiplex testing or NGS testing. And multidisciplinary meetings are definitely required for better understanding, and probably patients' wish, desires, and financial constraints have to be given more importance before deciding for which test to be preferred in a particular case of lung CA. And the important thing is it should have adequate tumor content, at least 10% or more. And there is a turnaround time of almost 10 days. And definitely high throughput platforms like NGS will come in a big way once the cost comes down. Yeah, next. So this is a chart which actually summarizes whatever I've already stated. And clinical guidelines definitely recommend a broad molecular testing uh, or even the rare driver mutations because they have a prognostic value. But I've already stated everything should be discussed with the patient as well as in the multidisciplinary tumor board. Next. So, in summary, biomarker testing has provided us with an avenue of individualized medicine in a non-small cell lung CA, and this is how this data is extrapolated to all other cancers that we deal with. And probably next generation sequencing has a big role to play for analysis of biomarkers in non-small cell lung cancer and for that matter any cancers. I thank AstraZeneca for providing me with the data that I've put in today. And I thank the audience for patient hearing. Thank you.
Thank you, Dr. Duncan, for a nice presentation on the molecular profiling of lung cancer. Because today is in the era of precision medicine, all lung cancer patients should have a molecular testing for early, specifically EGFR, ALK, ROS, and PDL1, and detailed molecular testing in advanced lung cancer. All should be tested. So it's a nice presentation.
Yeah.
Is there
Thank you,
any
sir.
question for the audience? Otherwise, we can directly go to the otherwise the next speaker will be Dr. Sanchayan Mandal. He is a senior medical oncologist at HCG Eco Center Hospital, Kolkata. He will speak on overview of lung cancer.
Hello. Am I audible?
Yes, you are audible.
Yeah, thank you very much for inviting me for this presentation, and thank you, AstraZeneca. So, as my previous speaker already give you a brief introduction that how in the current scenario, just about a decade ago, when this advancement in the medical oncology field has not been updated, and there is a lack of molecule that put add to the survival of the patient, be it advanced stage or be it on adjuvant therapy. With the advancement of this molecular studies and new molecule brings in our market like targeted therapy, immunotherapy, that actually helps the patient to add the numbers on the survival. And we have seen in our clinical practice that it actually helps the patient to do well even the patient has a metastatic or advanced stage of disease. So today my topic will be a overview of the lung cancer. So next slide, please. So first, let's see the Indian burden. How much India actually burdened with the lung cancer? Uh, Now, if we see Globocon 2020 data, the number of the incidents, the new cases, lung is in the fourth categories. Where if we consider the male only, the head and neck cancer is the number one, followed by lung. And in both cases, tobacco, be it a smokeless tobacco or smoking tobacco, is the main culprit. Next slide, please. Next slide. Next slide. So now if we see the changes in the AJCC, as you all know that there are some changes, minor changes in AJCC staging where there is a stage upliftment. And you can see that T3 more than 5 to 7 centimeter. If there is a N1 node is positive, then is upgrade to stage 3-1. Also, if it is a T4 tumor size is more than 7 centimeter, it is automatically to stage 3A. If the patient presented with N2 lesion, all are above stage T3 lesions are 3B, and N3 above T3 is 3C. Next slide, please. So now suppose one patient came to our clinic. We have to first seeing the imaging, we have suspected some space occupying lesion in the lung. Now we will do the diagnosis. Now to investigate more, we have the tools for staging. We have the invasive staging, some non-invasive staging like bronchoscopy, CT scan, PET CT scan, EVAS or endoscopic ultrasound, medistinoscopy, and MRI brain. These are actually the very important part of the lung cancer staging. Next slide, please. So if we can see that if we consider the CECT versus PET CT scan for staging the stage 3 non-small cell lung cancer, where the lymph nodes are more than 10 mm along the short axis, that a predictor of malignancy. And we can see that CT scan is basically a very low sensitivity specificity. So now in current standard, if the PET CT scan is available in our center, then definitely PET CT scan could be a better choice with overall sensitivity around 90%, specificity around 85 to 95%. Next slide, please. So we can see that risk factors for occult N2 not always detected by imaging. In case of central tumors, if you have the less size of the tumor, and if you have higher SUV and PET CT scan. Next slide, please. So we have to do the mediastinal staging. Then we have the less invasive technique, that is the EUS and EVAS guided biopsy, or a more invasive like mediastinoscopy, like conventional VAMLA or TMLA or VATS. Next slide, please. So these are the medical staging. Overall, there are 14 stations of lymph nodes. And if the clinical suspicions is N2 involvement remains very high after a negative EVAS and US, then surgical staging with mediastinoscopy is recommended. Otherwise, recommendation technique is EVAS or US. So next slide. Now, invasive mediastinal staging overall, in short, when it is indicated, if the central tumor is located, then yes, mediascopy will be the important choice. If the tumor size is more than 3 centimeter, if extensive infiltration of the mediastinum with no evidence of the extrathoracic disease or positive N1, then definitely we have to go for the invasive staging. Now, if there is a definitive bulky N2 disease visible on the CT scan imaging, so no need for any invasive confirmation. And if there is only the discrete N2 N2 disease is there, definitely we have to do the mediastinal staging regardless the PET CT scan. So normal mediastinum on CT scan, but if we repeat the patients on PET CT scan, if normal CT scan but positive on PET, definitely we have to clear the confusion. But if it is a negative on CT scan and negative on PET, then no need for invasive staging. Next slide, please. So this is actually the mediastinal staging algorithm protocol, where there is a PET CT scan with intrathoracic lung cancer with or without lymph node. If there is a mediastinal lymph node is positive, if it is a mass or bulky lymph node, then no tissue confirmation is required. If the node is non-bulky, non-mass, then tissue confirmation by EVAS or US. Now, if the mediastinal lymph node is negative, then multidisciplinary evaluation of surgical staging is needed. Mediastinal lymph node is negative again, then do for the therapy. If the mediastinal lymph node is positive, then definitely multimodality therapy is indicated. If the mediastinal lymph node is positive on EVAS, then we directly go for the multimodality treatment. Now, if the mediastinal lymph node is negative on PET-CT, then clinically N0, low probability of unforeseen N2 disease after negative PET-CT scan, then definitely we can go directly for therapy. But if there is a clinically N1 or clinically N0 and high probability of N2 disease after the negative PET-CT scan, then definitely we have to confirm the diagnosis by EVAS or US, and then according to the result, we will go for the either for multimodality therapy or directly go for the surgery or radiotherapy. Next slide, please. Next slide. Now, if we can see, there is a percentage of sensitivity, BRITA, upper mediastinal station, lower mediastinal station, or station 5, 6, hilar station or intralobular station. What are the sensitivity pattern different from the invasive and non-invasive mode? So we can see the PET CT scan sensitivity is around 80%, where EVAS and US the sensitivity is almost 90%. And if there is a EVAS plus US plus mediastinoscopy, 94%, and VATS is the highest, is a 99%, almost 100% sensitivity by VATS. Next slide. So how is the evolution of the therapy of lung cancer? As I before beginning of the session told, there is a definitely remarkable improvement on the molecular therapy as we using on our day-to-day life. So non-small cell lung cancer was once considered a single disease until distinct subtypes are characteristic identified, and it is clinically relevant to the treatment planning. So if we can see that traditionally there is a gross lung cancer, even a decade or 2 decades ago, we actually start the treatment on basis of just FNAC. Whereas now this diagnosis has been changed as the pattern of the histology, and according to the histology, we have the different molecules to offer to the patient to get the best benefit. So we have diagnosed in grossly on non-small cell and small cell, and histological breakdown on squamous, non-squamous, large cell adenocarcinoma. And after that, you have divided in different molecular pathology, what pathological alteration, mutation is there. And more recently, there is a immune checkpoint inhibitor. For that reason, we have to see the PD-L1 expression or tumor mutation burden like that. Next slide. So advance in management of non-small cell lung carcinoma actually has improved the survival. So there is a good journal, New England Journal of Medicine, where they have shown that the lung cancer specific survival improved from 26% that among among men in non-small cell lung cancer diagnosed in 2001 to 35% diagnosis 2014. So during these 13 years, there is a definitely advancement of the science with advancement of the newer molecule available to increase the survival of the patient. Next slide, please. So we can see starting from the 2006 up to 2020, we have a cascade, different cascades of these molecules are available in different indications. So there is an increase in approval of both targeted therapy and immunotherapy in non-small cell lung cancer. Next slide, please. So molecular targets, the molecular profiling in non-small cell carcinoma basically have their many alterations and the subtypes. Now all patients should undergo this type of molecular proliferation for targetable alteration, and there are different types of alterations available, although only 7 are FDA approved, against which the targeted therapies are available, that are EGFR, ALK, ROS1, BRAF, V600E, NTRK, MET, exon 14 skipping mutation rate. So this increase the need of the molecular testing in non-small cell carcinoma and should be the standard of care. Next slide, please. So what is the current guideline on neoadjuvant and adjuvant chemotherapy depend on the disease states or finding on the surgery? So we can see on left-hand side, there is a stage. If it is a stage 1, no lymph nodes are seen. Observation, there is no proven benefit of neoadjuvant and adjuvant therapy. If it is a little bit higher stage like 1B and 2A, then multidisciplinary team should discuss about the observation and adjuvant therapy, especially for the high-risk patient. No benefit for the neoadjuvant therapy. If it is a 2B in N0 or N1, then adjuvant therapy is recommended. And if it is a 3A or 3B, N1 and N2 lymph nodes are positive, then neoadjuvant chemotherapy or adjuvant chemotherapy or sequential chemotherapy and radiotherapy. Radiotherapy is indicated sequential therapy on N2 disease only. Next slide, please. So what are the findings of surgery that actually treatment decide your treatment later on is the margin. Margin is important where the resection margin as well as the pathological stage affects the adjuvant treatment decision. So you can see on left hand side there is a staging. If it is stage 1, stage 2A, R0 resection, observation and chemotherapy only for the high risk categories. If it is stage 2B, chemotherapy definitely needed, stage 3 and 3B chemotherapy, and if it is N2, sequential chemo plus radiation is needed. Whereas if it is the incomplete resection, that is the R1 and R2, so R1 is the positive margin on microscope and R2 is the residual tumor, there is a gross residual tumor left behind. So in early stage 1 or stage 2A, re-resection is preferred, but radiation is also an option. Chemotherapy is plus minus according to the precision of the physician. And stage 2B also there is a chance of resection plus chemotherapy is definitely we have to add as a form of systemic therapy to prevent the recurrence. And concurrent chemoradiation, be it R1 resection then sequential or concurrent. If it is R2, then definitely concurrent is needed. And where is the higher stage like stage 3 and 3B, where concurrent or sequential chemoradiation is very important, and R2 definitely concurrent is utmost important. Next slide. Excuse me. After initial treatment, so more than half of the patient with resectable non-small cell carcinoma experience the recurrence within 5 years. So you can see that after the surgery, if the patient has undergone some form of the radiation therapy or systemic therapy, 40 to 50% remain cancer free and 50 to 60% so recur. So it is a high chance of the recurrence. Definitely we have to work hard on this specific subgroup where we have to improve the patients even if as a tedious big surgery, resectable lesions. Next slide, please. So we can see that latest ESMO guideline recommend that adjuvant chemotherapy can be considered in patient with resected stage 1B disease if the primary tumor size is more than 4 centimeter, because there is a definite clear benefit is there. Next slide. And in less meta-analysis, overall survival is benefited from the post-operative cisplatin early stage non-small cell carcinoma. They have included the 5-pooled analysis where the cisplatin platinum-based doublet has been given. Mainly, vinorelbine cisplatin is the most commonly used, and that has led to increase in overall survival where hazard ratio is 0.89. Absolute benefit survival is seen in 3.9% in 3 years to 5.4% in 5 years. Next slide. So, if we can do the subgroup analysis, so we can see that 1B to 3A neoadjuvant chemotherapy hazard ratio is 0.87 and adjuvant chemotherapy is hazard ratio is 0.89. Next slide. So now Aurora trial, targeted therapy is now moving to the early stages after the resection. Inclusion criteria is patient completely resected stage 1B, 2, and 3A. EGFR mutated like exon 19 deletion or 8858 are mutated. And now they have included the trial in osimertinib versus placebo as the adjuvant therapy and for 3 years or for recurrence. Now it has been seen that 80% reduction in the risk of disease recurrence or death with osimertinib and is a super hazard ratio is 0.20, and there is a very early separation of curve. We can see the curve. There is a clear winner of this addition of the targeted therapy, and with the introduction of this EGFR TKI, the disease-free survival is improved from 44% in placebo group to 90% EGFR TKI. So almost doubled at 2 years. So it is now possible to further improve the survival in completely resectable disease in stage 1, 2, or 3 non-small cell carcinoma according to the ADAURA trial. Next slide. Another immunotherapy, as we have seen, as I have already told, that immune checkpoint inhibitor atezolizumab has also improvement in DFS as well as OS benefit in adjuvant setting. It has been seen in patients with more than 1% PDL1, and such therapy definitely increase the overall survival also. And there's a 36 months, the difference is 60% versus 48%. Next slide, please. So we have the different improvement in radiation aspects also. We have the much very finite form of the radiotherapy in form of IMRT in lung cancer, specifically the radiation oncologist people, they use the IGRT with respiratory gating technique. Next slide. And this is actually the most modern type of radiotherapy, that is called the stereotactic body radiation therapy versus conventional. And SBRT is the high dose radiation is given to the specific tumors, and there is a less tissue toxicity. So more dose of the radiation has been delivered to the tumor and killing the cells more effectively. Next slide. So these are actually the evaluation of the CT scan simulation during the radiation therapy. And actually by using this type of 4D CT simulation, they actually have the 3D image of the patient, where actually they have perfectly, they line up or draw the particular tumor, and then they shoot and kill the tumor cells. Next slide. So these are actually the RTOG 0617 stage 3 non-small lung cancer, where they have evaluated the dose of the radiation 60 gray versus 74 gray, and they have seen the 5 years overall survival is 60 gray is 32%, but 23% in higher stage. So 60% is the sufficient dose. Next slide. Next slide, please. So chemotherapy without radiation therapy, where if it is a stage 3 non-small cell carcinoma. So for stage 3, our medical oncologist should work closely with our radiation colleague and radiologist to have that specific plan about the specific patients. Eligible patients may unfit for chemotherapy due to many comorbidities or poor performance status. Not all patients complete the prescribed course of chemotherapy. So they have some options available if there is early stage observation, stage 1B or 2A, multidisciplinary to consult observation versus chemotherapy, which will be the beneficial for specific patient. Stage 2B chemotherapy and 3A, 3B definitely chemotherapy or sequential therapy for N2 disease only. Next slide. So another immune checkpoint inhibitor moving to the early stage, unresectable stage 3, it is the Pacific trial, where they have seen after chemoradiation, they have used the immunotherapy durvalumab for unresectable, and it has been seen that probability of overall survival is more with durvalumab, and there is early separation of the curve. Next slide, please. So with durvalumab, it has been seen 42.9% overall survival at 5 years in comparison to the 15 to 25% is the historical value. Next slide, please. So emerging treatment paradigm changes in treatment of the non-small cell carcinoma is the new evolution targeted therapy, immunotherapy. Next slide, please. So you can see targeted therapy in improving the advanced or metastatic stage, that 50% of this patient in India, especially when we came to our OPD, we actually diagnosed in the advanced form, either maximum stage 4 or some patients in stage 3. So in advanced non-small cell carcinoma, there are targeted therapy available like FLORA trial, where the PFS with first line of osimertinib versus EGFR first generation EGFR positive non-small cell carcinoma, they have seen hazard ratio 0.46, and there is very wide separation of the curve starting from the PFS benefit is there, and Alex trial where PFS is first line alectinib in ALK positive tumor versus crizotinib. There is also significant PFS benefit is there, and here hazard ratio is 0.43. So with this chemotherapy, the median PFS is 5 to 7 months, but with EGFR TKI, it has been increased to 18 months. EGFR TKI ALK inhibitor, it increased to 34 months. So it is a significant improvement of this progression-free survival in this type of patients. Next slide. So there are some other molecular target available for treating this, addressing this advanced stage of non-small cell carcinoma. Like if you have the MET exon 14 skipping mutation or MET amplification, incidence is although very less, only 3 to 5%. And we have the crizotinib with the early evidence of activity. Rate re-engagement is there, 1 to 2% occurrence only, occurs in both smokers and never smokers. We have the option of cabozantinib, vandetanib, and NTRK re-engagement less than 1%, mainly on clinical trial basis. Although I think in India it is larotrectinib, entrectinib has not been yet launched, and HER2 mutations 2 to 4% adotrastuzumab emtansine that we are using breast cancer. New targeted agents are being identified and will help to increase the survival in this type of subset of patients. Next slide. So with the recent advancement, survival rates are improving compared to the chemotherapy alone. So we can see the histological value, the yellow lines where there is only 8 months, 12 months, or 14 months, where with the use of this targeted therapy, immunotherapy, we have just doubled the number, and there is a list side effects also, patient compliance in case of having the patients on oral tablets, those are patient taking. Next slide. So these are immune checkpoint inhibitors. Next slide. So approval of immune checkpoint inhibitors over the time as the science advanced, starting from the 2014 to 2021. 2015 pembrolizumab in second line setting, if the PDL1 is TPS score is more than 1%, and nivolumab second line post platinum containing. 2016 atezolizumab in second line staging, and pembrolizumab on the first line setting if the PDL1 is more than TPS score is more than 50%. In 17 pembrolizumab approved for first line non-squamous along with the platinum and pemetrexed, And 2018, we have the atezolizumab as the first-line non-squamous with ABCP protocol, Pacli carbo bevacizumab. Pembrolizumab first-line therapy along with the nab-pacli and carboplatin, and durvalumab as the unresectable stage 3 after the CTRT completion. 2019, we have the atezolizumab first-line non-squamous on metastatic non-small cell carcinoma with nab-pacli carbo, and pembrolizumab as the first-line non-small cell carcinoma and stage 3 non-small cell carcinoma ineligible for resection, unresectable disease, or definitive CTRT with the tumor TPS score more than 1%. 2020, we have the nivolumab ipilimumab combination in first-line metastatic or recurrent non-small cell carcinoma with 2 cycles of platinum doublet. Nivo-ipi, if the PDL1 is more than 1%, is the first line, and atezolizumab if the PDL1 is more than 10% or TC is more than 50%. 2021, semiplimab, where the TPS score is more than 50%. This is the evaluation and changes in the indications upfront setting on changes in the immune checkpoint inhibitors. Next slide, please. Next slide. Immune checkpoint inhibitor has actually improved the survival in the non-small cell carcinoma. Next slide. Where we have seen that keynote 024 improved the survival in patient with pembrolizumab compared to chemotherapy, where the TPS score is more than 50%. We can use the single agent immune checkpoint inhibitor, and 32% patients are alive at 5 years with the use of immunotherapy in metastatic. This data is really surprising that even at a metastatic advanced stage of lung cancer, actually surviving beyond 5 years. That was not thinkable just before 20 years back. Next slide. So these are some ongoing trials where early stage lung cancer resectable. We have the immunotherapy in early stages like neoadjuvant setting with or without chemotherapy followed by surgery, or surgery followed by adjuvant immunotherapy with or without chemotherapy. So there are some trials on pembrolizumab trial is keynote 091, durvalumab BR31, Anvil, nivolumab, IMpower 0101, atezolizumab. Next slide. So what is the new antibody drug conjugate? As we have the Destiny Lung trial, and we have that trastuzumab deruxtecan recently launched in India. Next slide. And there are some evolution in CAR T cell therapy, which this one actually currently used in hematological malignancy, but now actually a trial is going on for many solid malignancy, especially in lung cancer patients, where they have included in some clinical trial. Next slide. So take home message, the management landscape is very fast changing in non-small cell carcinoma. New therapy is huge potential to improve the survival if the patient is detected early stage. Overall survival is improved various subtypes with the different molecular alteration, and it is a very, as I told, orally accessible for the patient, so patient can take the pill sitting at their home. And pulmonologist will play important role for very early diagnosis and referred us at very early stage so that we can plan this and give the maximum benefit to the patient in terms of survival. Next slide. Thank you.
Thank you, Dr. Sanchan, for your very nice brief thing about the management of lung cancer in short, but it was very nicely explained. And next two topics will be on a special subtypes, which those who are EGFR mutant NSCLC patient. So first, we have a discussion on real-world evidence of osimertinib in the treatment of EGFR mutant NSCLC. So I invite Dr. Amit Sharma. He's a medical oncologist in Narayana Hospital, Kolkata. Welcome, Dr. Amit.
Thank you so much, sir. And am I here audible?
Yes, you are audible.
Okay, good. So thank you so much, AstraZeneca, for giving me the opportunity. So today we are going to talk about the role of osimertinib in the management of EGFR mutated non-small cell lung cancer. especially the real world evidence we have right now. So next slide. So as we know that previously discussed as well by Dr. Sanchayan, that with in patient with EGFR mutation, we can improve the PFS really with the help of EGFR TKIs compared to the cytotoxic chemotherapy, especially with osimertinib, which is a irreversible third generation EGFR TKI. And it has demonstrated a median progression-free survival of 18.9 months compared to 10.10 months with the comparable EGFR inhibitor in the phase 3 randomized FLORA trial, and also the overall survival of 38.6 months compared to 31.8 months. Next slide. So this is we are going to talk about the FLORA trial. Next slide. So this is the schematic of FLORA trial. They included the patients with locally advanced or metastatic non-small cell lung cancer with the inclusion criteria of more than 18 years, with the performance status of 0 or 1, and EGFR mutation of exon 19 del or L858R. And there should be no prior systemic anti-cancerous chemotherapy or any EGFR TKI therapy. So it's a first line setting. And second thing is there should be CNS mets could be allowed, but they should be stable. And they are stratified in terms of mutation status and race, Asian versus non-Asian. And they are divided into two arms. One arm received osimertinib 80 milligram daily, 279 patients, and the comparative arm which includes either gefitinib 250 milligram OD or erlotinib 150 milligram OD. And they are evaluated using RECIST 1.1 criteria. And crossover was also allowed. And overall survival was supposed to be the key secondary endpoint. And final overall survival, it was planned to estimated once the 318 events of death has been occurred. Next slide. So this is the study population. We can see here in terms of sex, age, or any other criteria, including race, smoking status, or presence of CNS metastasis. Both the arms are pretty comparable. The only thing we can actually look into very nicely here is the patients who are having brain metastasis, CNS mets. CNS met, and we can see here the 19 patients in the osimertinib arm and 23 patients in the comparative arm has CNS metastasis at the time of study entry. Next slide. So look at the graph now, PFS. We can say the graph is getting separated very early, even before 3 months. I can see here 2 months, as early as 2 months, the graph is started separating, and it's keep on separating at the end of 2 years. We can see here, and if we look at the chart here, and all the way in all the groups, we can see there is a benefit with the osimertinib compared to the comparative arm. So next slide. Even in the case of overall survival, the final analysis, as we discussed earlier, that 38.6 months with osimertinib, with comparatively arm, there is 31.8 months. Hazard ratio is good, 0.79 with significant p-values. Graph starting separating early and keep on separating at the end of 50 months. Next slide. So to conclude very quickly, as we all know, the final overall survival analysis of FLORA reinforces the osimertinib as the standard of care in the first line treatment of patients with EGFR mutation in advanced NSCLC. Next slide. So as we see with FLORA trial, NCCN guidelines also approved osimertinib as a first line in patients who have sensitizing EGFR mutation. They can either start it straight away, or even if we don't know the EGFR mutation at the upfront and we started the systemic therapy, we can immediately switch over to the osimertinib as early as possible. We got the result. Next slide. Yeah, there it is. Next slide. Next. So now it's important to know the real world evidence as well, because in real world we have a lot of different, we don't have exact the same kind of population we treat as in ideal scenarios in trial scenarios. So it's important to know what is happening to our patients in real world studies. And there are three important studies we are going to discuss here: the flower study, ossifact, and myconus study. So go to the next slide. So this is the flower study as a first line osimertinib in patient in EGFR mutated advanced non-small lung cancer. This is observational real world study. Next slide. So as we already discussed, the osimertinib is a reversible third generation TKI. We discussed the benefit of PFS and overall survival with osimertinib. PFS, median PFS is 18.9 months and overall survival of at the range of 38.6 months with significant p-values. But why we need real world studies? It has been estimated that only 2 to 4% of our patients with cancer actually receive treatment within RCT. So it is important to know the real representativeness of our patients. So next slide. So this was the study baseline features. The median age was around 68 years. Most of the patients were female, 81%, 81 patients compared to 45 patients. Brain metastasis at the time of diagnosis is present in 30% of the patient. While we already seen in the FLORA study, there are hardly pretty much less patients included in other brain mets. But that's what we got in the real world. 30% of the patient have brain metastasis at the time of the study in these patients. Most of the patients belongs to stage 4. And yes, next slide. So these were the inclusion and exclusion criteria. Inclusion criteria include the kind of same inclusion criteria: age more than 18 years, histologically confirmed NSCLC, presence of EGFR mutations, and either locally advanced, recurrent, or metastatic disease. And they should be eligible to receive first-line treatment with third generation TKI. And exclusion should patient who receive the study drug in clinical trial are excluded in the studies. Next slide. So these studies take a unique way to evaluate the endpoints. One of the way was the primary endpoint was the median time to discontinuation. In real world, it's very to know that how effective our anti-cancer therapy. This could be a very nice way of knowing that how what is the median time to discontinuation, whether it is because of treatment related adverse effect or whether we have to do the regular dose reductions, whether it is temporary or definitive treatment interruptions. So this is one of the things which they evaluated as a primary endpoint, that is median time to discontinuation, and the secondary was as we use in other trials like OS, response rates, and PFS. Next slide. Next slide. So how they are different from our FLORA trials are: patients in these studies, patient we have with poor performance status. As we know, in FLORA trials they only allowed 0 or 1 performance status. We have in real world patients with comorbidities. In real world we have rare EGFR mutation present as well. In real world we have more patients with active brain metastasis. So in these studies, these kind of patients are also included. Outcomes are similar to the published data, which we see the outcome results, and there was no difference in the survival rates, which we will see in the next slides, coming slides. Next slide. So this is one of the outcome which we are trying to find out, that is time to treatment discontinuation. We can see here a median time to treatment discontinuation is somewhere around 25.3 months, and it depends on whether the patient present with symptoms initially or not present with symptoms initially. So the patient who are present with symptom initially, the time of discontinuation is a little bit lesser, that is 18.8 months, and whether also it is also dependent on whether the number of metastatic sites is less than 3 or more than 3. So if the patient has less than 3 metastatic site, then median is still to reach. And if the time to discontinuation is more, if there is more than 3 metastatic site, then the time to discontinuation is 21 months. So it basically time to discontinuation is depending on two important things. One is symptoms present or not. Second is number of metastatic sites. Next slide. This is, I think, the same slide repeated. Next slide. So time to the last slide, last line. This is different. That in the time to discontinuation is actually more suitable endpoint in our real world scenarios in a practical way. Time to discontinuation is longer, 25 months, than the post progression outcome analysis of FLORA trial, which is somewhere around 20 months. It is probably due to our population is, as we discussed, is more is a poor PS patients, have more comorbidities, and they have active brain metastasis. That can be a reason. And next slide. Next slide. So this is the overall multivariate analysis. There are certain things which are actually. Can you put next slide? Yeah. So the important thing, as we discussed, is the presence of symptoms or not. If you look in all the other variables, you will see the p values are significant only in certain groups, subgroups. One is subgroup with presence of symptoms. We can see here there is a p value which is significant for overall survival as well as time to discontinuation. Next slide. Next slide. Next. And same thing which we have discussed earlier, the number of metastatic sites is also important. So we can see here p values again significant for number of metastatic sites less than 3 versus more than 3, in not only in overall survival as well as time to discontinuation rate. As also the presence of brain metastases at the time of diagnosis is also showing significant p values in PFS metavariate analysis. Next slide. So when we look at the effectiveness wise, what we see in our regular trials is median follow-up at the end of 12 months. The median PFS was 18.9 months, which is quite similar with FLORA. Median overall survival is still to reach. And in terms of response rates, we can see here almost 90, more than 95, around 95% patients has response rates, either PR or stable disease. Next slide. So this is regarding PFS. We can see here the median PFS is somewhere around 18.9 months. Presence of brain mets influence the PFS. We can see here when there is no brain mets, the median is still to reach. And with with brain mets, PFS is going down to 13.3 months, and the p value is significant. Also, it also depends on whether a present of symptoms or not. If the symptoms are present, median is still to reach, and if the symptoms are present, then the median PFS is 15.5 months. If symptoms are not present, we still do get median PFS. Next slide. I think this is a repeated slide. Next slide. In terms of next slide. Yeah. So yeah, this is the here. So essential element of evidence in this is a real world diagnostic, as we already discussed, that it is important that we as a clinician we must know that in our kind of patient population what are the results we are getting. And so these real world studies are important in that way. In these patients, among patients who are expecting having progressive disease, out of them 21 cases they have analyzed this thing as well. Out of 44 patients, half of the patients underwent biopsy at the time of progression, and out of them 14 cases underwent liquid biopsy. And molecular analysis was performed in around 13 samples. And the reason of progression on osimertinib was in our this study population was MET amplification was found in 4 patients out of 13, and EGFR amplification and along with MET amplification found in 1 patient. EGFR amplification alone was found in 1 patient, and HER2 amplification was found in 1 patient. Next slide. Safety data, we all know that what are the common side effects of osimertinib. Like pneumonitis is one of the side effects which we worried about, and most of the patient has grade 1, grade 2 side effects, like somewhere around 7%. And other side effects include diarrhea, stomatitis, and rash is important. And dry skin and paronychia is also very important side effects. Some under evaluated, I think the venous thromboembolism, sometimes we don't worry about that, but this is something which we should look into when the patient is on osimertinib. And Next slide. Yeah, these things is being highlighted in this slide. Next slide. So out of 110 patient, almost 87% patient some sort of adverse effect, but only 1/3 of the patient have grade 3-4 side effects. As I already told, that venous thromboembolism is one of the common side effects, and also one of the other real world study Asterisk also told us that grade 3 pulmonary embolism occur almost around 2% of the patient treated with osimertinib. Next slide. No difference in rates of VT when we think about age, performance status, comorbidity, or tumor load. Next slide. So this is the same thing which you have been told, irrespective of age or performance status, no difference in VT. Next slide. Next slide. Next. Yeah. Next. So this is the second study. It's a second real world study. This is OCFECT. Let's see what this study is saying. Next slide. So these are the same thing which we are going to be repeated, that osimertinib has the value in EGFR mutation mutated non-small cell lung cancer. Next slide. So this is the inclusion criteria of OCFECT study, advanced EGFR positive non-small cell lung cancer with osimertinib as the initial treatment. This is the inclusion criteria. And exclusion criteria: and a patient concurrently receiving any other anti-cancer therapy or any radiation, or undergoing post-operative adjuvant chemotherapy, or receiving osimertinib as a second-line treatment. These patients are excluded. Next slide. So these are the basic characteristics of these patients. Next slide. Yeah. Next slide. So important thing, no, previous slide. So most of the things are actually the general study criteria which have been used. The important one thing they have included, the reason I don't know, that is PDL1 status they have also included. They have divided the PDL1 status into more than 51 to 49 and less than 1%. We will see the results of how it has been worked out. Next slide. So the endpoints was, primary endpoint was progression-free survival, and secondary endpoints were overall survival, time to treatment failure, response rates, and objective as well as disease control rates. Next slide. So PFS event occurred in 182 patients out of 538 patients, and median PFS was 20 months, 25 months exactly. Next slide. So this is shown by the graphical manner. And the important thing is the PFS was associated with male gender, malignant diffusions, liver mets, and advanced unresectable cases. And these are the some of the things where PFS was low compared to the other patients. Next slide. And also with respect to PDL1 expression, median PFS was non-reached in patient with TPS less than 1, and 14.7 months with TPS less than 49%, 11 months in those with TPS 50%, and non-reached in patient TPS unknown. We can see there that the more the TPS, the median PFS is low. Next slide. So if you look at subgroup wise, as we have already discussed that male sex was important contributor to PFS values. PDL1 status we have discussed in the previous slide. Next slide. So sex was important. Next slide. Malignant infusions were important. Next slide. Presence of liver mets is important. These are the components where p values are significant, and stage is also important. Next slide. PDL1 we have discussed. Next slide. So what was the reason of treatment discontinuation in these patients? Out of 219 patients, we can see here 44% of the patients have discontinued because of disease progression, and 25% of the patient discontinued because of the side effect, that is pneumonitis. And there are so many other side effects which including anorexia, skin disorder, or cardiac failure, QT prolongation, fatigue, anemia. And because of these reasons, 16% of the patient discontinued. Lost of follow-up in 14% of the patient. Next slide. Yeah, we have discussed. Next slide. So these we all know these are the common side effects, and the median duration of onset of pneumonitis is somewhere around say 8 weeks. Yes, and rest of the side effects as we expected, as we usually expect. Next slide. Next slide. Next slide. So to conclude this study, overall response rate was very good, 76%. Disease control rate was 94%, and PFS is better with osimertinib. Median time to failure was 19 months. Median time from start of the treatment to the onset of adverse effect was somewhere around 56 days. Pneumonitis of all grades is present in 69 patients, grade 3 or higher in only 4.5%, and fatal pneumonitis in only 4%, 4 patients. To conclude, PFS after first-line osimertinib treatment in real-world practice is favorable, and the discontinuation rate due to adverse effect is somewhere around 18%. Next slide. So these were the final study, Mykonos study. We will discuss what is the findings of this study. Next slide. So again, background is similar. The study, the osimertinib is third generation. We have already discussed. We have discussed the result of FLORA-3 study. So we know the reason why we are doing real world studies. Next slide. So this was again the global observational study, which went on in the US, Europe, and Asia. And during the study period, we have de-identified data from around 280 US clinics. And patient inclusion criteria was more than 18 years of the age, advanced in non-small cell lung cancer, either stage 3B or 4. EGFR mutation should be documented prior to starting of first-line osimertinib monotherapy. And these are the patients who are initiated for first-line osimertinib from April 1, 2018 to March 31, 2020. Next slide. Same thing. This is the schematic of the trials study, how it went on, starting from the whole analysis has to be finished, actually finished by June 30, 2023. Next slide. So the important thing which they have estimated is TT and TD, that is time to the real world data of time to next treatment or death, and time to discontinuation. TTD is same as the previous study we have discussed, time to discontinuation, and TT and TD is time to next treatment or time to death. So how real world TT and TD was defined as the time from index date until the start of the next systemic therapy or death in the absence of any other next systemic therapy, and TTD is the time index date from the earliest end date of osimertinib associated with discontinuation. Next slide. So this is the patient profile, more or less similar as we have seen in the other trials. Next slide. Yeah, these are the study patients. They have also included Charlson comorbidity index and number of metastatic sites and evidence of liver metastasis present or not, or brain metastasis present or not. We will see how it affects the results. Next slide. So EGFR mutation positive was present in all 548 patients. Most of those patients have 50% of those patients have EGFR exon 19 del, and L858 are present with around 1/3 of the patients. And both common and uncommon mutation was present in somewhere around 22 patients. Uncommon mutations were also detected here in 52 patients, and unknown mutation in somewhere around 5 patients. Next slide. So treatment sequencing, obviously we started with first line osimertinib in these patients, and once there was the discontinuation, they received second line treatment based on the physician choice, whether PD IO or IO alone or IO chemotherapy. There are different subgroups. By the time of interim analysis, we can see here what are the findings. Out of 380, there is 318 patients, which is somewhere around 58%, which remained on first line osimertinib therapy or were lost on follow-up. 18% of the patient received second line treatment, and 18.4% patient died. So 18% received second line, 18% patient died, and for 4.7% patient discontinued. Next slide. So the median follow-up time was 9.6 months for RWTT and TD. Median RWTT and TD was 17.9 months. and there were on 204 events, out of which 101 patient, 18%, as we discussed, died. 18% switched to second line treatment. Next slide. In the multivariate analysis, RWTTND was dependent on stage of initial diagnosis, smoking status, comorbidity index, EGFR mutation type, and number of metastatic sites, whether it is more than 4 or less than 4. And this is has been seen in the forest chart as well. Next slide. And similar kind of thing we have seen in the RWTTD, that is median RWTTD was 17.2 months. And there were 30 events, 18.4% died, 18.8% switched to the second line. Next slide. And TTD was also dependent on comorbidity index, whether it is more than 3 or less than 3, performance status more than 2 or less than 2, EGFR mutation present or not, number of, EGFR mutation type, whether it is DEL 18 or 858R, number of metastatic sites, presence of more than 4 or less than 4, or presence or absence of liver metastasis. This is the forest chart we can see here. Next slide. So to take home message is our real world insights. Echoing the results which we have find out in the RCTs and interim RWTT and TD and RWTTD results support the effectiveness of osimertinib in real world population as well. Long-term outcomes will also be find out in the final analysis, which is yet to be done. Next slide. So I think this is from my side. Thank you so much for all the patient hearing. Thank you so much.
Thank you, Dr. Amit, for presenting the real-world data of osimertinib in EGFR mutant NSCLC patient. So now we have a final session that will be a panel discussion, and the topic will be role of osimertinib in EGFR mutant NSCLC patient who are metastatic. And the session will be moderated by Dr. M.D. Chandrakant, and he is a senior medical oncologist of Narayana Hospital, Kolkata. And I invite Dr. Chandrakant to take over the proceedings.
Thank you, Dr. Anupam, for that very kind introduction and laying out the foundation. Can I share from my side?
Yes, you are audible and slides are visible.
Yeah, so I think my slides are visible right now. Yeah, okay. So I think we have panelists, Dr. Naresh, Dr. Dulal, Dr. Navakumar, Dr. Rajiv, and Dr. Kaustav. Okay. I would thank the organizers for this opportunity, and let's go through a case discussion on management of early stage lung cancer. So this is the case. We have 67-year-old gentleman who is a non-smoker, presented with cough, and X-ray showed a small lesion in the left upper lobe. CT chest showed lesion in the left apical lobe. And this is how the CT scan and the PET CT looks like. The left upper lobe small lesion is there. And this is the impression of the PET CT. So it reads out that intensely FDG of it, well-defined lobulated soft tissue nodular lesion in the apico-posterior segment of left upper lobe with adjacent pleural tax, non-FDG avid subcentimetric prevascular lymph node, and no other site of metastasis. So, Dr. Naresh, how would you proceed from this point? Okay. If there is no Dr. Naresh, then Dr. Dulal.
Hello.
Yes, yes.
So,
Yes, sir.
so as we have seen that there is a lesion in the left apical lobe, and I have not noted the size, but by the look of it, it was looking like 3 into 3 kind of size. So we will definitely go with a like CT guided biopsy for this patient, and as per the biopsy report, we will proceed.
Okay. So we will do a biopsy, and the biopsy is adenocarcinoma. Okay. So now I will move to Dr. Navakumar. Dr. Navakumar, now it is adenocarcinoma, and this is the scan report. So what will you do right now?
Yeah, so definitely it's an look like an lung cancer, and
We could not hear you, Dr. Navakumar. Like
relative
there is
nodes
some
are already
intermittent.
present. Am I audible?
Yeah, now you're audible.
Yeah, so this is looks like a case of early lung cancer. So I will refer the case to my surgical oncology colleague for proper medicinal evaluation and staging, which is very important for if you want to proceed for surgery, and other ancillary tests like your biomarker testing and other like your pulmonary function tests. So all these things has to be
Very correct. Very correct. So I think you made very valid points. Most important is
for the
mediastinal staging, which is very
metastasis.
important. And of course, we can also do an MRI brain and then PFT DLCO to look for lung reserve and so on. Okay. So I think MRI brain. Yeah, I think we do MRI brain in all patients. Okay. So I will go to Dr. Rajiv Paul. Rajiv Paul, and I think in early lung cancer, we do MRI brain to rule out metastasis in the 10%, or you do it in only specific subset of patients.
As per guidelines, even in my practice also, in early lung cancer, I do not do routine MRI brain, except if the patient is having any symptoms or any N2 disease, in locally advanced cases, then only we'll do MRI brain. Otherwise, we do not do MRI brain.
Okay. Then coming on to mediastinal staging. So, Dr. Kaustav, what would you do about mediastinal staging? You would do an EBUS or a mediastinoscopy before or during surgery itself, you will address. How will you look into Dr.
No,
Kaustav?
yeah. Am I audible?
Yes, Dr.
Okay.
Kaustav.
So before surgery, you have to evaluate the mediastinal and lymph nodes only. So might be the EVAS would be a good choice to evaluate because there is though there is lymph node but non-FD habit, but we must be sure that the lymph node is totally
Yes,
negative. So EVAS is the must.
correct. So mediastinal staging is important. Okay. So is getting tissue sampler biopsy a challenge in a early lung cancer? So Dr. Dulal.
Yes, Dr. Chandrakant, for a person or for a physician sitting in a tier 2 city like Jorhat, I'm practicing here in Upper Assam. So there is definitely a problem of getting the tissue from my patients. Most of the time, when I send the patient to a radiologist for a like CT guide biopsy, they end up doing a FNSC and they refer the patient back to me. So I was like compelled to refer the patient to a higher city, tier 1 city like Guwahati, or so there the patient can be biopsied. So definitely the expertise is important. Getting a biopsy done in a tier 2 city or in a resource limited setting, it is definitely a challenge. Definitely a challenge.
Very relevant points, Dr. Dulal. I think the same even we face in tier 1 cities at times, because if the tumor is small and if it is centrally located or its accessibility is not easy or there is a small pleural lesion, I mean it's difficult to have an access for it. And I totally agree. Like 40% of times the tissue is inadequate for molecular tests, even in advanced cancer. So it is a challenge. Agreed. But however, if you do a surgery, then you will have adequate tissue. There probably will be able to have. So this is the guidelines like, no, yeah. So this is the guidelines. This is 2021 guideline, however. So for non-small cell lung cancer, and let's see what the guideline says. So you will do PFT, you will do in stage 1A, you will do PFT, you will do bronchoscopy, and then mediastinal staging, FDG PET. If it is negative nodes, operable surgical exploration resection, including mediastinal lymph nodes. If it is inoperable, then definitive RT. Then if you have a stage 1B, 1C, 2A, and so on, there you will do PFT, bronch, FDG PET, and MRI brain. So as it was previously said, in a very early stage, stage 1A, you may avoid MRI brain, but if it's stage 2 onwards or if it's stage 1B onwards, um, stage 1B, it's optional MRI brain, whereas stage 2 and 3A, MRI brain has to be done. And as it was said, 1B, we may avoid MRI brain. And then again, the mediastinal lymph nodes to be addressed accordingly. So this is some important message. Stage 1A, avoid MRI brain. Stage 1B is optional. Stage 2 and 3A, you must do an MRI brain. Okay, this is about brain staging and mediastinal lymph node staging. Okay, for this patient, let's come to US has no enlarged mediastinal lymph nodes, medically fit, underwent surgery. This is the post-operative report. 2.9 is the maximum size of the tumor. Micropapillary invasive adenocarcinoma, acinar pattern, margins are uninvolved, and then you have so many lymph nodes. So it turns out to be a T2N1 disease. Okay. So you have 2 reactive, 7 reactive, 2 lymph nodes with in bottle 4, section 10 and 11, station 10 and 11, you have 2 lymph nodes with metastatic deposits. Okay. So ENE is absent. So this is a PT2N1 disease. Okay. So now again, I'll be back to Dr. Nabakumar. So Dr. Nabakumar, let's go to the first question. Do you check for any molecular biomarkers in early lung cancer? Okay. Then I'll go to Dr. Rajiv. Dr. Rajiv.
Yeah, definitely. Biomarker testing.
Sir, there is a network issue, sir.
Hello.
Probably you may, yeah. Now you are better. Okay. So, sir, you again disconnect connect back, sir. Probably you will be able
Can
to.
you hear me?
Yeah.
Can you hear me
audible
now?
Yes. Go ahead. Okay. So organizers get in touch
Yeah.
with.
So
Yeah.
biomarker testing is biomarker testing is essential. So for early so pre-surgery tissue or post-surgery, both can be applicable, and biomarker testing has to be done. So we are generally we generally do the biomarker testing for early lung cancer in our patients.
Okay, so you would like to do biomarkers. Okay, Dr. Rajiv. So you can take the second and the third questions. So yeah.
Yes, sir. Usually, biomarker testing in this case, I will go for in the lobectomy specimen, and or IC is sufficient. No need to do multigen panel in NGS panel testing. IC is sufficient. At least EGFR should be done.
Correct. So you will do EGFR at least because you have a targeted therapy addressing it. Okay. And because you will have adequate sample, you will do a post-surgical specimen.
Post-lobectomy specimen.
Perfect. Okay. So you can actually do an NGS also. You know why? because if you want to give durvalumab, okay, this is
Yeah.
adjuvant, no? Yeah. So
Yeah.
if you want to give adjuvant IO, let's say now there is adjuvant IO, data is there for adjuvant IO now.
Okay.
So there, if you want to avoid immunotherapy, maybe you can do, but it's fine. EGFR, a must, yes.
Yeah.
Others is optional, as you correctly pointed out. Perfect, perfect. Okay, now Dr. Kaustav, you can take these questions. Do all patients with early lung cancer undergo surgery? If not, what percentage do not undergo, and what are the possible reasons? And what factors should be
So,
considered? So all these are interlinked. You can answer all the questions.
okay. So there are regarding the surgery, there are few things we have to take in consideration. First is the ideal indication. Second is the technicality, and third is the logistic issue. So if we consider for the indication, so if we go for the stage 3, also consisted of the into sometimes the into diseases. Okay, so into disease, if it is more than C-station involvement is there, then sometimes the surgery is not feasible. So in those cases, the indication might just exclude those patients. Second is the technicality. So there are some consideration regarding the FEV1 or PPO, FEV1 or PPO, DLCO ratio and everything. That is the PFT, lung function test. If it is not good or the cardiac function test is not good, then that is if the patient is medically inoperable, then obviously we don't go for surgery in those cases. And third is obviously the logistic issue, because this cardiac surgery is not available in all the places in the, I mean, each and every part of the India or the world. So in those cases, we might land up doing in those places only if radiation is there. So we land up doing CTRT in those patients without going for the surgery. So these are the few. There are few issues we have to faces before going for any kind of surgeries. Second question, if you can go for, if not, what percentage don't undergo resection? Okay, if you can see in our center, it's a high volume center, so we can if we select around 100 patients for the surgery, ultimately I mean in the early stage, ultimately 30 to 40% case land up to doing surgery per se in those cases only. Okay, it's our experience. Okay. And what is the possible reason? The possible reason I have already told you in the 3 points regarding these things. And what factor should you consider to determine the riskability? Determine the riskability. One of the major factor is this PFT and the cardiac function test in those cases. That is it medically operable or not? This is the most important things I should consideration before going.
I think you answered all questions, Dr. Kaustav. Very nice. Okay, so we understood what are the challenges of resection and what are the possible barriers for it and what are the factors. So everything we heard from Dr. Kaustav. Now let us go to radiation. So role of post-operative radiation and role of SBRT in early non-small cell lung cancer, and which patient should receive. So Dr. Naresh has joined. Dr. Naresh, you want to take up this question? Yes, Dr. Naresh. This is a radiation oncology question. You unmute, Naresh.
Yeah, so post-operative RT in early stage lung cancer, basically we have data from older studies which say that uh, the benefit is a bit dicey, but situations wherein post-operatively, if you land up with an N2 disease or or maybe sometimes an N3 lesion also with number of nodes coming out to be positive, then with the current radiation, post-operative radiotherapy does have a role. And there are studies which have shown that there is an tendency towards survival benefit in those scenarios, incidentally detected N2 and N3 diseases. When we talk about SBRT, generally patients with early non-small cell lung cancer who are medically unfit for undergoing lobectomy and in whom the call is between a segmentectomy versus an SBRT, because segmentectomy has always been shown to have inferior outcomes compared to lobectomy. In those cases, SBRT probably does a better job. But then in those scenarios, you would preferably want a pre-therapy biopsy or at least an FNA to undergo, because you don't have a post-operative sampling. So I think that's a scenario where I would consider SBRT and port for an incidentally detected N2 and N3 diseases, or bulky N2 in certain cases if the patient has undergone surgery.
Very good. I think you
So
very
I
well.
would like to, sorry, Dr. Chandrakant,
Yes.
I'd like to just mention one
Yes,
extra point
Kaustav.
for the port.
Yes.
That is the any still any margin positive case we have to add port in this case.
Yes. Yes. Correct. Agreed.
Absolutely. Absolutely.
So that is the indication for post-operative radiation and SBRT. I think we very clearly defined the criteria. Now coming on to neoadjuvant chemotherapy. So neoadjuvant, I will go to Dr. Dulal back. Dr. Dulal, when do you use neoadjuvant chemotherapy in your practice?
I generally use neoadjuvant in cases like where patient has a very bulky node, and if in a multidisciplinary tumor board, a surgeon is telling that they can venture into the
True.
surgery after chemotherapy, then only I will go into the neoadjuvant therapy. Otherwise, I will straight away take this case to
Correct. Correct. So
radiation.
N1 will go for surgery. N3 is for CTRT. If you have a N2, and
Yeah.
which is DAISY, like
Mm.
multi-station, single station, whatever reason, if there is N2, in that set of patients, instead of resection, you may give neoadjuvant chemotherapy in these patients. Perfect. Okay. So this patient is a stage 2, T2N1, and the molecular panel is showing the exon 21 mutation, L858R. So T2N1 node positive disease will qualify for adjuvant chemo also. So Dr. Navakumar, so what will you do? What adjuvant treatment would you want to give for this patient? Navakumar's network is an issue today. Sir, am I audible? You're speaking? Okay, so he's not audible. So Dr. Rajiv, you can take it up.
As a surgical oncologist, I will take this refer this case to medical oncologist. But as per guidelines, this patient will require adjuvant chemotherapy. As EGFR is positive, so osimertinib with chemotherapy will be enough, I think.
Okay, then I should have asked you all surgical questions before. I was asking medical oncologists surgical questions. Surgical oncology, medical. Okay, so you believe that the
Yeah.
chances of systemic recurrence are higher.
Yeah,
Lung
yeah, in this
cancer
case.
is a systemic disease, and any node positivity means there is a high chance of recurrence in these patients. And you
Yeah.
believe that for your surgery to be successful, there should be a good adjuvant treatment.
Adjuvant treatment.
Excellent. So, surgeon has agreed for adjuvant treatment. He wants to give adjuvant chemo and also adjuvant TKI. Okay, let me go to Dr. Kaustav. Dr. Kaustav, what is your opinion? Do you want to give chemo, or you want to give TKI, or you want to give both?
I mean, it's better to if you can answer the question or any medical oncologist. But yes, according to the new data, we can consider for the TKI and also chemotherapy. We can give only chemotherapy, or only TKI or chemotherapy followed by osimertinib, the TKI, according to the new data. So yes, if you can ask my opinion, I should consider for the adjuvant chemotherapy first, because it's the age-old procedure, age-old thing already established by various meta-analysis. We consider for the 4th cycle of platinum-based therapy followed by a osimertinib for 3 years.
Perfect. So I think you are correct, Kaustav. So in the trial also, in those patients who qualify for adjuvant chemo, any node positive will qualify for adjuvant chemo. So this patient will require adjuvant chemo. After that, you can give adjuvant TKI, that is osimertinib. So, Dr. Kaustav, what adjuvant chemo do you use usually in adenocarcinoma?
Normally, platinum-based therapy is a adenocarcinoma, so we might consider for the pemetrexed and cisplatin-based therapy 4 cycles.
Perfect. So there is data for cis, vinorelbine, and so many. But we use pemetrexed cisplatin 4 cycles as the standard of care in adenocarcinoma. Perfect. And TKI. So, what about TKI, Dr. Kaustav? How long you want to give? And
So
what TKI?
regarding that, there are various previous data from either, I don't know, there is a Radiant trial, I guess, if I'm not wrong, of the this orlotinib data.
Okay.
The data was not that very effective, but there are some DFS benefit, but no OS benefit was there. And and there are some CNS progression is very likely in those cases. So
Correct. Very good.
yes, that was one options was there. Second option is the newer data of Adura trial, which we are going to discuss, I guess, the osimertinib data, and which has after the 2 years, that is the median follow-up of 24 months, they have given a very good overall, I mean DFS benefit, not the overall survival, DFS benefit in this case. So yes, but regarding this new data, we might consider adding osimertinib as NCCN also adding up in the new guideline.
Very good. I think you said very correctly. This is the adjuvant chemotherapy benefit. This is the LACE meta-analysis saying 5%, 5.4%, 5-year overall survival benefit. These are the 5 randomized trials, and the meta-analysis is showing that. So that is about adjuvant chemo. So if a patient qualifies for adjuvant chemo, the patient should receive adjuvant chemo. And then this is the benefit of adjuvant cis, we know, and the stage wise benefit. This is how it is. So the higher the stage, the lymph node being positive, the benefit of chemo is much better. Okay. So then this is the Adora trial, what Dr. Kaustav was delving into. Adjuvant osimertinib and EGFR mutant early stage lung cancer, stage 2A EGFR mutant should we give? And this is the staging, like stage 2 was around 1/3 of patients. So this patient was sort of falling in the inclusion criteria of the Adora trial. And this is the benefit of 2R3A. So you can see the benefit of stage 2 or 3A, and the hazard ratio is 0.17, which is very impressive. And there's the DFS benefit also. So this is the DFS benefit of osimertinib versus placebo. And if you have 1B also included, the hazard ratio is 0.2. And the endpoint is DFS. This is the Radiant DFS, what Dr. Kaustav was delving into. The hazard ratio is 0.61 and 2 to 3A, and the primary endpoint DFS in 2 or 3A is 0.17 in the Adora trial. So the Radiant versus Adora, there is a significant benefit in the Adora. The hazard or the magnitude of difference is more. And this is the CTONG DFS. Again, Geftinib versus vinorelbine plus cisplatin. And you can see again here the hazard ratio is 0.6. And the overall survival with Geftinib is not there. It is not statistically significant. So I will go to Dr. Naresh. So Dr. Naresh, so what is your take on this? On using osimertinib in adjuvant and on using first generation or other TKIs as adjuvant?
Well, if we see from the evidence perspective, the quantum of benefit seems to be maximum for osimertinib, the third generation TKI. Also, we know that the first generation TKIs do not provide adequate protection in the CNS, which is a very likely site of recurrence, especially when your disease at other sites is controlled. So, if you weigh the data in terms of benefit, in terms of hard endpoints like DFS, which is a realistic endpoint when we talk about adjuvant settings, with the 3 drugs that we have, and also the pharmacokinetic and the evidence from the metastatic setting which osimertinib has. So I would be tempted, if my patient is able to afford, I would be tempted to offer them osimertinib, because you only get one chance at curing these patients.
So that's the crux of the discussion, Dr. Naresh. I think you put it nicely. Okay, so let's go for the pattern of disease, local or metastatic. 11% of patients in osimertinib arm had DFS events versus 46%, and the majority of patients with recurrence had local regional recurrence only, with only 38% of patients having metastatic recurrence versus 61%. Just focus on this graph. Any location, so is so less in osimertinib versus the other arm. Lung is less, lymph node is less, CNS is so less. So read through the CNS one. So the CNS is a common site of distant. I think this is what Dr. Kaustav was saying. CNS is a common site of distant recurrence, and patients with EGFR mutant have a higher CNS chance of CNS mets. In the adjuvant radiant study, 37% of recurrence in patients with EGFR mutation treated with erlotinib had CNS involvement. But look at in this, just only 6 of them had CNS recurrence. Therefore, having good CNS uh, protection is very important, and therefore osimertinib wins over the other TKIs. That is what Dr. Costa was mentioning. Dr. Dulal, this is the question to you. Is the ADAURA trial practice changing?
Uh, Definitely, this trial, this data is practice changing. Definitely, early on, we used to give adjuvant chemotherapy only in such cases, but now we will be considering osimertinib with like more back of like data to back us. And the thing is, the only I think the only hindrance will be the cost of therapy in Indian settings, because we see that the monthly cost of therapy to the patient is very high. We all know how much is it. So that is definitely a hindrance. So if we can like go off this hindrance gradually, then definitely it will be like more useful for our patients, and it will be practice changing.
Very good, Dr. Dulal. So Dr. Navakumar is back. Hi, sir. Nice to have you. So, sir, your final comments
Yeah,
and your
very pathetic.
yeah, yeah.
Yeah,
So, yeah, your comments on adjuvant osimertinib and any experience how you have been using this in the setting, sir.
yeah, Aurora has been very eye opener to all of us, because we know that the benefit of adjuvant chemotherapy, if we consider from stage 2 to stage 3. So if you see the 5-year survival in chemotherapy versus placebo is just hovering about 5 to 6%. And the hazard ratio is also not so pretty encouraging. So since we don't have any therapy, but with the advent of osimertinib, you can see that the hazard ratio is pretty hovering about 0.17 to 0.12. Sorry, 0.17 to 0.2, so which is pretty good and encouraging for all of us. So it will be, I think it will be a practice changing for all of us in the future. So few of us, of course, I don't have any experience of using it in the adjuvant setting till now, though I have experience in the metastatic. But surely, if some patients comes up and really fits into the therapy, and definitely I will advise the patient for adjuvant, because it is just life changing for the patients.
Very nicely put, Dr. Navakumar. So thanks for your very valuable inputs. And this is the NCCN guideline. You can see NCCN guideline chemotherapy for those who are at high risk, and osimertinib is also there if they are EGFR mutant. So it's a category 1 recommendation in stage 1B, stage 2A, 2B, and 3A and beyond. So that is about the final message. I think we had a very fruitful discussion from all the panelists. So I would thank all the panelists for your valuable inputs. And if there are no other comments, we can conclude this session.
Yes, thank you, Dr.
Yeah,
Sandukant and panelists for a nice panel discussion. And within a very short period of time, we had a very nice and fruitful discussion on the management of lung cancer, with special reference to those EGFR mutant patients, both early as well as advanced disease. And it was very nice to be here along with you. And I offer my sincere thanks to the organizers, three speakers, and the panelists, and as well as moderator Dr. Sandokan. And now I hand over the mic to the organizers.
Thank you for joining, everyone. Have a good day. Good night.
Good night.
Good
Thank you
night.
all.
Good night.
Yeah.
Good night.
Thank you. Thank
Thank you, everyone.
Technical support, kindly close the meeting. Hello. Technical team, kindly close the meeting, please.